Let us continue with our session on how to interpret a microbiology reports. Rule number one is always start with a beta-lactam antibiotic if possible, especially in severe infections, because they have the best data supporting their use and are in general excellent drugs, except in case of atypical infections. Rule number two, do not compare MICs between drugs, because every antibiotic has different serum concentration, different tissue concentration, different pharmacokinetics. Each antibiotic has different pharmacodynamic parameters. There are time-dependent antibiotics, there are concentration antibiotics, there are AUC by MIC-dependent antibiotics. Rule number three, if the MS is sensitive, if you can still use the drug, except when the drug doesn't get to the site of action, drug doesn't achieve pharmacodynamic parameters, drug doesn't have invisible resistance, specific factors, and the drug costs. Rule number four, microbiology always has more information than what is reported. They may have the results more than before than what is reported to the computer. Antibiotics may be separate. They can perform additional testings. So that is about the four rules for interpreting the sensory testing for selection of the rational antibiotic. Now take this case, which antibiotic will you use? All the antibiotics are sensitive. Ampicillin, daptomycin, penicillin, vancomycin, and organisms enterococcus faecalis. Then consider the rules. Rule number one, beta-lactam antibiotic. Now the drug of choice will be, for this case, will be ampicillin. Rule number two, the drug of choice, do not compare MICs. Then daptomycin, vancomycin are available, but still they are not, they won't be preferred. Ampicillin will be the stick out drug of choice. Rule number three, if it is less than equal to that is sensitive, you can use the drug with some exceptions like cost effectiveness. Then considering the cost effectiveness, ampicillin will be preferred than vancomycin and daptomycin. And rule number four, microbiology has more information, so we can test for linezolid also, but which is the oral option. But still, seeing the cost issue of linezolid, ampicillin will be the drug of choice. Various rules or guidelines or various parameters needs to be considered while interpreting the sensitive result for selecting the rational right antibiotic. Say again, this specimen of urine culture wherein Klebsiella oxytocca is obtained and it is ESBL producer. All the antibodies are resistant and it is an ESBL producer except the sensitive antibiotics are cefotetin which is sensitive, and then levofloxacin, meropenem, nitrofurantoin are sensitive, peptide is intermediate, and tigecycline is sensitive. Now which antibiotic? We need more information in this case, whether it is cystitis or pyelonephritis, if cystitis is male or female, if female then how old. Let's assume this is the case of cystitis in a young adult female with no comorbid condition. And other case, it is a question, what is what is that do you want? You want IV? Then consider the four rules. Rule number one, always a beta-lactam antibiotic. So C14 and meropenem are the beta-lactam antibiotic. We can proceed with this, but since the organism is ESBL producer, we won't be considering C14 and meropenem. And since come to rule number two, do not compare MICs. So we will not consider C14 and meropenem. Let's move to the other sensitive antibiotics. If it is less than equal to sensitive, then you can use the drug with exceptions such as it should not be an ESBL producer, so C14 and meropenem will be not used. They are IV drugs, so they will not be considered since preference will be for oral drugs. The Ciplox is resistant, so because of the cross-reaction issue, levofloxacin will not be used. Tigecycline is a very poor urine penetration, and it is IV also, so tigecycline won't be preferred. So the drug of choice left is nitrofurantoin. Since microbiology always has more information that can be reported, so the first one information can also be tested. But since it is expensive, we will continue with the antibiotic nitrofurantoin. So rules can be used to interpret the sensitive result for determining the right test and antibiotic. Take another case, a 67-year-old smoker on exam presents with fever and cough, no recent travel, no worse of the patient history. What would be most helpful in the making the immediate diagnosis? Which are the tests? So these are the four options. Now, which will be the option that will be right? Full blood count or CBC, C-reactive protein, urine and urine electrolytes, urine dipstick, and chest X-ray. Why? Because the total WBC count and the differential will give information of the likelihood of the infections. Urine electrolytes will give us knowledge of renal function. CRP will help us to understand whether it is a bacterial infections. Urine dipstick will help us to understand whether it is a urinary tract infection. Chest X-ray is as per the criteria of Thoracic Society for diagnosis. Now, what was observed was there was a rise in WBC There is a rise in the CRP, there is a rise in the urine filtration and creatinine. Dipstick was positive where nitrates were reduced nitrites. And the chest X-ray shows consolidation. That is signs of. Now, what is the most likely diagnosis? Diagnosis was community acquired pneumonia because the WBC were raised, CRP was raised, hence it is an acute bacterial infection. Even that the urine is considered diagnosis of ATI, but what dual infection is very rare. So, the diagnosis of pneumonia, and since chest X-ray was also showed signs of consolidation, so the diagnosis of community acquired pneumonia was made. Now, on the basis of the chest X-ray, the patient is re-examined to look for signs of pneumonia. Then, what is signs of pneumonia here? There are four options available. Let's have a look. Which will be the most? Which of the following is not a sign of pneumonia? So these crackles. Crackles are not signs of pneumonia. Crackles are signs of heart failure or fibrosis rather than consultation. Now, what are the further investigations ordered where sputum culture, blood cultures, and urine for legionella antigen? Repeat clinical examination was done first. Now, what will the sputum appearance in case of community acquired pneumonia? Since sputum was sent for culture, there are four options. Purulent. Purulent appearance of sputum can help in distinction whether it is contamination or infection. Salivary means colonization. Mucoid means contamination. Purulent indicates infection and inflammation. Therefore, it is consistent with the diagnosis of. It was observed that the saturation decreased, temperature increased, heart rate was increasing, respiratory rate was increasing, and the patient was having rigors. Now, what will be the antibiotic that will be started on empirical therapy? These are the four options. IV coamoxiclo and clarithromycin. Most hospitals use a combination of beta-lactam and a macrolide antibiotic. Peptides will be unnecessarily a broad spectrum. Gentamicin will not penetrate into the chest. So clindamycin is often considered with a macrolide. It is actually a lincomycin and has a different spectrum of activity. However, it doesn't have any action against atypical bacteria or non-culturable bacteria. So clindamycin will be avoided. Then we are left with coamoxiclo and clarithromycin. Teicoplanin and levofloxacin are often used for, but it is reserved for severe community acquired pneumonia. Patient's diagnosed with community acquired pneumonia started on coamoxiclo and clarithromycin. Curve score is 65. The curve 65 score is 4. And this is how the curve 65 score look like. Now, which of the following is not a cause of community acquired pneumonia? Pseudomonas aerogen is a cause of hospital acquired or healthcare associated infection and associated with chronic obstructive pulmonary disease. The common causes of community acquired pneumonia are staph aureus, streptococcus pneumonia, H. influenza, microbiology pneumonia, legionella, chlamydia, and viral causes. Next day, the bloods revealed high WBC, high CRP, urea ultrasound increased. Microscopy, the culture, urine culture was yielded no growth. Microscopy, pustules were high numbers in urine. Blood culture yielded a gram positive cocci. Now, how will you manage this patient now? Will you change it, the antibiotics, or will you stop it, or will you persist with it? Persist with it because there is no reason to suspect that the patient has anything other than the causes of community acquired pneumonia. It's mostly likely that he needs more time to response. The results were followed at 48 hours. Urine yielded no growth. Blood cultures yielded coagulation negative staphylococcus, that is contamination. Sputum yielded staphylococcus pneumoniae, and urine was positive for legionella antigen. What is diagnosis? Legionella pneumophila pneumonia. Because the urine antigen test was positive for legionella pneumophila, which has sensitivity of 95, sensitivity of 95%. So growth of streptococcus pneumoniae sputum can occur in absence of pneumonia also, and can because of normal colonization. The presence of cons in a blood indicates contamination. So this patient was diagnosed as legionella pneumophila pneumonia and was notified to the patient or the treatment. What will be the treatment of choice for the legionella pneumophila? Levofloxacin for 3 weeks because levofloxacin superior to clarithromycin has a good oral bioavailability. The patient was converted to oral levofloxacin eventually and continued for 3 weeks course of treatment. So let us understand the guidelines for such how to interpret this such results. In any case, the results of sensitivity testing needs to be interpreted with some background knowledge of pharmacokinetics, pharmacodynamics, and the organisms and the patient's history. Do not use the antimicrobials if these are not necessary. Always take into account the natural resistance of the organisms. Check any unusual results. Drug test needs to take into account the pharmacokinetics and pharmacodynamics. Dose adjustments should be precise for avoiding any sublethal concentration. Wherever possible, use a narrow spectrum antibiotic and resort to most resort antibiotics for exceptional cases. That is about how to interpret sensitive testing. We have molecular detection of nucleic acid or polymerase chain reaction or NAT test. A positive PCR reliably guides empirical and targeted antibiotic therapy. A positive PCR does not warrant stoppage of therapy as co-infection of viral and bacterial pathogens may coexist. Then we have various multiplex PCR channels like respiratory, GI, blood culture, meningitis, and lower respiratory. Molecular rapid diagnostic tests like NAT or microarrays or FISH or which are available for the identification of organism as well as the gene detection like MECA, VAN-A, VAN-B, VAN-C, and the issue with the rapid molecular diagnosis is that there are few direct methods, but they eliminate cultures, longer incubations, it includes examples like PCR or microarray and DNA chips. Rapid detection is an advantage, it helps in quick decision making. However, it provides false results at times leading to reduced time to effective therapy. Interpretive challenges is an issue again. False positives may occur because of contamination. It cannot differentiate infection, contamination, and colonization, and it cannot differentiate between live and dead organisms. False negatives can occur because of the shift and drifts. So we have point of care tests like which are quicker and easy to perform. This it provides same day results like lateral flow assay or immunochromatography tests. Examples are antigen detection of malaria, antibody detection of HIV, and others. The advantage is it provides immediate initiation of the antibody therapy, reduction in unnecessary antimicrobial consumption, reduction in the cell temperature, and other such advantages. But however, the disadvantage is that there is a lack of data. You cannot distinguish between live and dead, contamination or colonization, and isolates are not available for sensitivity testings. The examples of such POC to rapid diagnostic tests include influenza AB, or respiratory syncytial virus, or streptococcus or COVID-19 testings. Antigen detection the clinical helps to laboratory to conduct a test for urinary pneumococcal and vaginal antigens. The clinical details state that outbreak of diarrhea and vomiting, and the lab can conduct tests for norovirus and rotavirus in stool in such outbreaks on immediate basis. So that's the advantage of intelligent detection cards. There are also toxin detection cards such as Clostridium difficile toxin detection from stool. There are host inflammatory biomarkers available such as CRP, procalcitonin, galtamin, and beta-glucan. The clinical significance of biomarkers is that it is good, they, but they are the most available biomarkers like CRP and procalcitonin. They are good, but imperfect diagnostic performance is an issue. They have no role in routinely guiding the initiation of the antibiotics. Clinical judgment is necessary. They are useful markers to discontinue therapy after stabilization. Procalcitonin non-clearance is a predictor of mortality in patients with sepsis. Protein is again an ichthyophase reactive protein. It has a slow induction, it has a low specificity and no correlation with severity of infection. It can be used to monitor the course of infections. Then we have procalcitonin. There is a rapid induction, its levels quickly decline at a predictable rate. However, the issue with procalcitonin is the cost is a major deterrent. It helps to distinguish the viral infection in early course of disease and other causes of infection and inflammations. So this is how the values of procalcitonin helps. Procalcitonin less than 0.1 units, better than infection unlikely. Procalcitonin more than 0.5, better than infection very likely. And accordingly, the antibiotics is either discontinued or stopped or continued. Then we have fungal biomarkers like beta-glucan and beta-glutaminone. They are FDA approved only for serum and BAL. They have a high negative rating. So there are various advantages and disadvantages from beta-glucan and galtaminone. Beta-glucan is very routinely used for Candida aspergillus, while galtaminone is specific for aspergillus. They have a good high sensitivity and specificity, good taste, and efficient active biomarkers for fungal and infection. Take home is that there could be an infection without culture positive mica without infection. It only the objective defined infection. Normal flora should never be treated. Use the correct test and use the biomarkers judiciously. Thank you.